Hello, everybody. Welcome to Grand Rounds. And today is our annual Henry Nasrallah lecture. This is an endowed lecture named after and made possible by Henry Nasrallah, who did his medical student training here and is one of the leading schizophrenia researchers and editor of two journals. Some of you know Henry. So each year we bring in someone who's really a pioneer and someone who's doing excellent work and has been doing excellent work for a long time, really a leader in the field, a thought leader in the field. And we certainly have that today with Dr. Elaine Walker from Emory University, who will be speaking on from social context to neurobiology and the etiology of psychotic disorders. I'm going to give her a real introduction in a minute, but I just wanted to mention a few things for people watching on Zoom that we always say. So one is if you're watching on Zoom, your cameras and microphones are turned off unless you're the speaker or an interpreter. So that's how it's supposed to be. Also, please do not use the chat box. We do hope people have questions and comments at the end, but make sure you put those in the Q&A box and send them that way, and we'll get through as many as we can in the last few minutes. Yeah. And I hear if you're lucky enough to be called on to ask your question to the audience, wait till somebody, me or Brian or somebody, gives you the microphone. We'll be coming around with it. So use the Q&A box for the questions, and then make sure to fill out the evaluation at the end or tomorrow. There'll be an email sent out. There'll be a QR code and a link put up on the slide at the very end of the talk today. It's important that we get everybody's feedback. Okay, so moving on. And every now and then we get someone who's really just done an incredible amount of work and had an incredible amount of influence on the field. And that's what we have today with Dr. Elaine Walker. So Elaine is the Charles Howard Candler Professor of Psychology and Neuroscience at Emory University. She got her bachelor's at Washington University at St. Louis and her PhD from University of Missouri, and did a postdoctoral fellowship at USC. Most of her career has been spent as a faculty member at Cornell University and then at Emory University, where she's been since the mid-1980s now. Among the administrative positions that Elaine has had are president of the Society for Research in Psychopathology, director of the graduate program in clinical science, and also chair of Emory's Department of Psychology. She leads a research program that's been funded by the NIMH and other places, foundations, for example, for over 35 years. And for those of you not old enough to know what an accomplishment that is, let me just say it's extremely difficult to reach that goal. Her research program has been focused on risk factors for major mental illness, especially psychosis. And I know her, I've been aware of her work since the 80s, and it's certainly caught my eye, and she's done some very interesting and influential studies. Her research is really focused on the behavioral and neurobiological precursors of psychotic disorders, and she was doing that before it really became the popular trend that it is today. And in fact, her work has really inspired a lot of that work that's going on now. And you may know that there's a lot of work now on people identified as being at clinical high risk for psychosis. And again, a lot of that work is influenced by the earlier work that Elaine did and current work as well. Let's see. The goals of Elaine's work are to enhance accuracy in predicting psychotic disorders. That we still could be a lot better at that, and we are getting better slowly, but it's still very difficult to tell who is going to develop a psychotic disorder among all the people who you might think are going to develop one. In addition to identifying people, she's focused on understanding the neurobiological antecedents of psychosis and also focusing on preventive interventions. That's a dream really in psychiatry. You know, can we prevent psychosis, the development of a psychotic disorder in people that we know are at highest risk for developing it in the near term? And that's what our high-risk clinic that we have in our department is all about. Along with her colleagues, and I should say many students who have gone on to really distinguished careers. It's quite a long list of people who I met many years ago as young students, and now I'm not going to say they're old people, but they're certainly established faculty members with very longstanding successful research programs. So she's published 5 books, over 450 articles, given many presentations. She's the head of the Emory site for the Naples study, which is the North American prodrome longitudinal study, one of the major studies of risk for schizophrenia. And she's received many awards. I'll just mention a few here. The Zubin Memorial Award, which is given to a leader in schizophrenia research, the APF, American Psychological Foundation's Gralnick Award, Cattell Foundation Award, the SRP, Society for Research in Psychopathology Lifetime Achievement Award, the SRP John Neal Lifetime Mentorship Award, 2 NIMH Career Development Awards, et cetera. And she's a fellow of the American Association for the Advancement of Science. So as I told Elaine, I could spend an hour just talking about the work she's done and how influential it's been, but probably better if we just see for ourselves. So without any further delay, I'm going to turn it over to Elaine. And Elaine, there's a lot of people here, and we're all looking forward to your talk.
Thank you so much, Steve. That was a very kind introduction. I am going to share my screen now, I hope. And you should be able to see a PowerPoint presentation. So as Steve mentioned, I'll be talking about social context and neurobiology in the etiology of psychosis. And it's especially an honor to be doing this as the Nasrallah lecture. I have been so impressed over the years with the many accomplishments of Dr. Nasrallah. And it's a wonderful thing to be able to give this lecture. I am having a little trouble. Okay, there we go. Forwarded my slides. One of the things that has impressed me so much over the years about Dr. Nasrallah's career is his impact in so many domains of research on psychotic disorders, especially. He was among those who first considered neuroinflammatory processes, stress, trauma in psychosis, and offered hypotheses regarding neural circuitry. So he has indeed been a pioneer in the field. I'm going to be talking today about 2 lines of research, time permitting. The first will be on individuals at clinical high risk for psychosis, and again, time permitting, a little bit about copy number variations, genetic syndromes that confer heightened risk for psychosis. Before I begin, I want to just state some of my general assumptions at this point. First, I assume that psychotic disorders involve abnormalities in brain function that can originate in additive and interactive processes involving pre-existing vulnerabilities, and that neuromaturational processes are involved in moderating the expression of vulnerability. The fact that the modal age range for the onset of psychosis is late adolescence, early adulthood, highlights the fact that it likely is playing an important role in altering the expression of vulnerability and potentially also offering clues about mechanisms. Whoops, wrong way. And as we know, the adolescent period, young adulthood, is a time when there are dramatic changes in the brain, changes in structure, function, circuitry. And many, if not most, risk factors for psychosis, including genetic risk factors, appear to have transdiagnostic relevance. So they cut across major mental disorders. And alternatively, a way of thinking about it is that risk factors for psychosis are nonspecific. They're associated with increased risk for a range of psychiatric syndromes. So this figure illustrates kind of the life course with respect to the origins of vulnerability and the factors that play a role in its expression. So we know now that at least for some patients, there are pre-zygotic processes, mutations, changes in the genome that can confer risk, and that during the prenatal period, there are, of course, a host of factors that can alter fetal brain development. Those include the physical environment, as it's affected by maternal stress or infection, for example, as well as mutations, epigenetic processes that can occur during fetal development. And then beyond that, into adolescence, young adulthood, there are a host of factors that can increase risk. Those include other epigenetic changes, as well as substance use, cannabis use, for example. This slide illustrates some of the many neuromaturational events occurring during adolescence. And one that I'd like to highlight here, because I'll be getting back to that, is the change in gray matter volume over time. So a reduction in gray matter volume is a normal developmental process. So for people who have raised adolescents and have maybe thought, gee, are they losing their minds? Technically, to some extent, they are losing part of their cortical matter, but in a way that is enhancing function, of course. So during adolescence, there's synaptic pruning that plays a role, undoubtedly, in changes in cortical volume. There's changes in density and surface area in the cortex. And there are changes in neurotransmitters and neural circuitry. So the brain is undergoing a kind of remodeling. This slide shows changes during adolescent, young adulthood, actually starting at age 7, in cortical gray matter volume. And as you can see, there's a decline for both males and females. And this has been replicated many, many times. An important thing to keep in mind is that developmental change is not uniform in trajectory across all brain regions. So, for example, in the cerebellum, there's a sexually dimorphic pattern of developmental changes. In some regions, the amygdala, the hippocampus, there is actually an increase in volume. So there's a dramatic reorganizational process that's occurring during adolescence that we think plays a role in why adolescence is such a critical period. Now, we of course know there are gonadal hormone changes during adolescence, but it turns out that there are also changes in the HPA axis. And this results in an increase in cortisol secretion. So thinking about the effects of hormones on the brain, including the factors that can trigger hormone changes like stress, we generally conceptualize them as falling in two categories. So first, there are the activational effects, the transient effects of cortisol and other hormones on brain function, neuronal function. But then there are also organizational effects. So these are structural changes in neurons and brain circuitry that are mediated presumably by epigenetic processes. And I'll be talking about the hippocampus, among other brain regions, in this talk. And it turns out that the hippocampus is particularly vulnerable to adverse effects of heightened glucocorticoids or stress hormones. This is an illustration of the impact of glucocorticoids at the synapse. This is taken from Bruce McEwen, who was instrumental in developing our understanding of stress neurobiology. And he showed that there are both non-genomic and direct genomic effects of glucocorticoids, and those alter neuronal function either in a transient or a permanent way. This figure shows changes in cortisol secretion in healthy individuals across the lifespan. And it illustrates very well with a large sample the increase in cortisol through the course of adolescence into early adulthood, then a decrease and plateau and an increase again later in life. So we think of adolescence as a period of heightened stress sensitivity as a function of, in part, changes in the HPA axis. These figures show changes in psychotic-like symptoms, which it turns out are not that uncommon in adolescence and typically decline with age. But whether you're looking at definite psychotic experiences or just suspected psychotic experiences, there's this increase during adolescence that then plateaus as individuals enter early adulthood. Again, pointing to the critical period of adolescence. Now, I mentioned transdiagnostic risk. This is from a very recently published study looking at the predictive power of polygenic risk scores. Polygenic risk scores for schizophrenia on the left, for bipolar disorder and major depressive disorder. The predictive power to psychosis. And what you can see here, looking at the upper part of the figure, is that polygenic risk scores for schizophrenia are, as we'd expect, predictive of psychosis, but so are polygenic risk scores for bipolar disorder and major depressive disorder. This particular study also showed that there was a sex difference, with males having polygenic risk scores with greater predictive power to adolescence. So using the same polygenic risk algorithm and weights, more predictive in males than females, although significantly predictive in both. Also, I think it's worth noting here that the proportion of the variance doesn't achieve 10%. So the proportion of variance in psychotic outcomes explained by polygenic risk scores is modest. Okay, I'm going to turn now to a discussion of some of our research findings from the North American Prodrome Longitudinal Study. This is a multi-site longitudinal study focused on youth showing clinical risk signs for psychosis. And the goal of this study was to improve our ability to predict psychosis for ultimately purposes of preventive intervention, and also shed light on the nature of vulnerability and how it unfolds through neuromaturational processes. We had multiple post-baseline follow-up assessments, and there have been 3 protocols used in Naples. The first phase of Naples utilized a simpler protocol shared across sites. It became more complex in Naples 2, and that's shown here. Then in Naples 3, we increased the number, our density of our follow-ups. And at most follow-ups collected both clinical data and also biomarker data, including psychophysiology and MRI. Some of you are familiar with the SIPS, the Structured Interview for Psychosis Risk Syndromes, shown here. And this particular instrument taps into a wide range of symptoms, positive, negative, general. But the focus when it comes to designating someone as meeting criteria for clinical high risk is on the positive symptoms. And those are shown here. So they include unusual thought content, suspiciousness, grandiosity, perceptual abnormalities. And we rate all of those on a scale from 0 to 6, with ratings in the range of 3 to 5 being designated as clinical high risk levels of severity. The 6th level is considered to be severe and psychotic. So youth who meet a 6 criteria on any one of the positive symptoms on the SIPS would be considered to have crossed the threshold into psychosis. Only those rated 3 to 5 on the symptoms, on any one of the symptoms, is considered clinical high risk. I should note also that a big distinguishing factor between a level of 6 and 3 to 5 would be conviction. So once the individual meets level 6, they have strong conviction. Also, to clarify some terminology, you'll see in some results I show that clinical high risk subjects are referred to as prodromal patients, other times as clinical high risk, and sometimes, not in our research, but in some other countries, the term ultra high risk is used. And conversion refers to that transition from the clinical high risk state into a level of severity that exceeds the threshold for clinical psychosis. So converters are those who go on to develop psychosis. Non-converters do not develop psychosis, at least in the follow-up period covered. So one of our first challenges, of course, was to demonstrate the predictive power of the SIPS. And we and others have done that, showing using survival curve analysis and other procedures that among clinical high risk or prodromal individuals, the maintenance free from psychosis declines over time. But that's not the case with controls. So the conversion rate varies as a function of the duration of the follow-up, and it tends to increase over time. Okay, important to note, again, with respect to transdiagnostic phenomena, that clinical high-risk individuals tend to be highly comorbid. So here we see that out of a total from Naples 2 of our 744 clinical high-risk youth, 444 had met criteria for unipolar depression. And following them up, some of them remitted, but that was a minority. Most of them maintained that diagnosis. In other words, they continued to meet criteria for unipolar depression. So high levels of comorbidity. In Naples, we have looked at a range of functional domains In particular, those domains that have been shown to be impaired in individuals with psychosis, especially first episode psychosis. So these are data from Naples showing the neuropsychological performance profiles of healthy controls, clinical high risk non-converters, that's the NCs, and clinical high risk converters. There were 89 of them. And what you can see looking at the factors derived from that neuropsychological battery is that individuals who at baseline subsequently went on to develop psychosis showed greater deficits than did those who did not. So the lowest performing group at baseline were the clinical high risk subjects who went on to develop psychosis at follow-up. And those who did not fell midway between the converters and the healthy controls. When we look at role functioning, social functioning, not surprising, we find a similar pattern. So compared to healthy controls, the top green line, we see that the clinical high risk converters, the red line, showed greater deficits in social functioning and role functioning, and that spanned from adolescence, pre-adolescence into the 20s. The same with role functioning, which for youth would be academic functioning. And looking, for example, at psychophysiological risk signs, in particular, startle and pre-pulse inhibition, we see that the clinical high-risk converters, the orange line here, showed elevated startle response latency. And that was, again, especially the case if they went on and converted to psychosis. Also, we looked at cannabis use in this particular study and found that there were some differences between cannabis users and non-users. I won't go into that, but basically the cannabis users had depression in startle response latency. Okay, I'm going to turn now to the issue of stress. So we administered a life event stress scale. It's one that has been used in research in many studies of psychopathology. And what we found is that the clinical high risk youth showed elevated stressful life events. So this was a cumulative scale compared to the healthy controls. And that difference increased with age. So we found the normative increase in self-reported stressful life events in both healthy and clinical high-risk individuals. But it was more pronounced in the clinical high-risk group, and it tended not to plateau the way it did for healthy controls. This shows cortisol levels by age, and we replicated the often reported now age-related increase in cortisol secretion, and we observed that it occurred for both healthy controls and clinical high-risk individuals, but with a mean difference at each age. Going back to the baseline assessment, we then, at our follow-up diagnostic evaluation, went back to look at cortisol levels at baseline as a function of whether the individual converted to psychosis, showed a progression but didn't convert, remained symptomatic at the same level, or went into remission. And we compared those to the control baseline level. And what we found is that the clinical high-risk subjects who converted to psychosis had shown a higher level of cortisol at baseline compared to the remitted clinical high risk and the controls. So evidence that there might be a predisposition or a vulnerability to stress that we were detecting at baseline. Now, among the most important, I think, findings from Naples 2 was that there's a decline in cortical gray matter with age that exceeds that observed in healthy controls. So if we compare in the upper left-hand side converters versus controls, we see that there's a greater loss in cortical gray matter, or thickness in this case, in the converters compared to the controls, and in the converters compared to the non-converters. Also, this held when they were corrected, the statistical results were corrected, and it was pretty uniform across males and females. So rates of change in cortical thickness were greater in the clinical high risk than the controls, and especially in those who converted. This shows a little additional information about that study. One of the concerns was, well, there's some evidence that antipsychotic medication can have an impact on cortical changes. So we looked at these rates of change in cortical thickness and found that they were somewhat greater in the medicated group, but didn't differ significantly from the other high-risk subjects. So whether medicated or not, there was a decrease in prefrontal cortical volume and an increase in ventricular size, the third ventricle in this case. We also looked at resting state connectivity, and in particular, looking at global efficiency, comparing non-converters to controls, and also comparing converters to non-converters. And what we found is that there was reduced global efficiency on fMRI in the clinical high-risk individuals who converted to psychosis when compared to those who did not convert and when compared to the controls. So we're seeing changes in functional connectivity that distinguish the converters from the non-converters. And I should note that this was most pronounced, as you can see, on the C line of this slide, that the default mode network seemed to be the most important. Okay, so we have developed several prediction algorithms from Naples. And some of you may have seen this. It was published, the first rendition, and is accessible online. You can plug data in to get a prediction. So first, we looked at predicting the probability of conversion among clinical high-risk individuals at 2 years. It was 16%. And using machine learning, we found that a series of variables were predictive. Higher levels of unusual thought content, suspiciousness, declines in social functioning, deficits in verbal learning and memory, slower speed of processing, and younger age at baseline. Then in a subsequent study, we took that same algorithm and decided to see if the use of polygenic risk scores, polygenic scores for psychosis, could help in prediction if added to this algorithm. And what we found is that there was an increase in prediction. However, when the polygenic risk score was added to the risk calculator, it did not significantly increase prediction. So that means the C index was unchanged. But then in a more recent study, cortisol levels were added to the algorithm. And what we found was that by adding cortisol, there was a significant increase in prediction of conversion. So a 7% improvement compared to the model without cortisol. So this was the first time that we had evidence using a biomarker that predictive power could be improved. I should note that for each standard deviation in cortisol, risk for psychosis increased 17.5 times. So that was the first time we used a biomarker for prediction that turned out to add to the clinical measures we had previously used. Whoops. Okay, I'm going to turn now to environmental factors and brain morphology. There has been, of course, a host of animal studies, some of the earliest conducted by Bruce McEwen and colleagues, then human studies showing that exposure to adverse environments had an adverse impact on brain morphology. Most recently, one of my graduate students published a paper distinguishing between childhood adversity and childhood threat, and found that it was associated with reduced cortical limbic volumes in clinical high-risk youth. So let me go on now to how we started exploring this issue of the relationship between adverse environments and brain structure using geocoding. So one of my mentees, a resident who's now a faculty member, named Benson Koo, decided to start using geocoding to derive variables that indexed various characteristics of the childhood environment. Among them, social fragmentation, which is generally defined as greater transiency and disruption in social structure and family structure. Ethno-racial minority density. So that refers to the degree to which one's ethno-racial group is represented in their childhood environment or their neighborhood. Area deprivation index is sort of a generalized index of access to financial, physical, and educational resources in the community. So in one of the first studies, we looked at the relationship between social fragmentation and social functioning in youth at clinical high risk, and also maladaptation at school. And what we found is that there was an effect, a direct effect that was significant of social fragmentation on the child's social functioning. In addition, there was an effect on adaptation at school. And adaptation or maladaptation at school mediated in part the effect of social fragmentation on social functioning. So looking then at a very global index of the individual's childhood environment made it possible to predict current social functioning, which of course in our clinical high-risk youth tends to be impaired. In this study, the focus was on ethno-racial minority density. So the sample included clinical high-risk youth who were ethno-racial minorities: Hispanic, Black, in neighborhoods in the United States. And in this study, Benson and Deidre Anglin, a young faculty member, looked at the relationship between area level minoritized childhood ethnic density and perceived discrimination. We also had a measure of that in Naples 3, and the relation with remission of psychosis risk symptoms. In other words, a reduction in the severity of the positive symptoms measured on the SIPS interview. And what was found is that the impact, which we already knew was a negative impact of area level minoritized childhood density, ethnic density, predicted perceived discrimination, as had been shown by previous investigators. And that in turn was predictive of the extent of remission of psychosis risk outcomes. So these were individuals who showed either a total remission, no psychosis risk syndromes on follow-up. So again, this is an important, I think, indicator of how some global environmental indices can influence self-perceptions that have implications for contributing to clinical high-risk symptoms, and also account for some of the observations of ethno-racial differences in risk for psychosis. Another study, in this case, looking at the relationship between environmental characteristics, in this case, looking at ethno-racial minority density and cortical thickness, and again finding evidence that the adverse effect of reduced minority density for minorities is partially reflected in brain structure. In particular, in this case, the relationship between thickness of the fusiform cortex, our gyrus, and some other adjacent brain regions. So lending some support that these neighborhood or contextual effects are partially mediated by changes in the brain. Okay, I went over this previously. I can skip this. Again, just defining the area deprivation index based on geocoding. It involves multiple indices, so it's a multivariate index. But looking again at that area level deprivation index and its relationship with hippocampal volume, in this case, right hippocampal volume, it was not significant for the left. We found that there was a relationship between area level deprivation and reduction in hippocampal volume in clinical high-risk youth. And in part, that was mediated by characteristics of the school environment. It was not the case with respect to characteristics of the family environment. So school environment was mediating some of the relation between area level deprivation and hippocampal volume. Now, I mentioned that we measured cumulative life event stress and recently looked at the relationship with that measure with cortical thickness in clinical high-risk youth. Couple of, I think, salient issues to note here. One is that we found a main effect of greater exposure to life event stress for both the healthy controls and the clinical high-risk youth. So these two columns illustrate the presence or absence of correction for multiple comparisons. But the interesting thing is that there was an effect that was independent of diagnostic group. There was also a main effective diagnostic group, indicating that the relationship between higher exposure to life event stress and cortical thickness was stronger for the clinical high risk group. And that was also, of course, reflected in this interaction between life event stress and diagnostic group. More recently, with this same graduate student, Katrina Aberis, we looked at the relationship between connectivity using structural equation modeling and hippocampal volume. So the objective here, whoops, sorry, I went forward, was to examine connectivity structural relationships, in particular to determine, as some animal studies had shown, that hippocampal volume was sometimes linked to cortical connectivity, and that association was influenced by environmental exposures. So that was based on animal models. In this case, we're looking at clinical high risk and healthy youth. For the healthy youth, it's the red lines. The blue lines are the clinical high risk, are the blue lines of the clinical high risk youth. And then the green lines are constrained. Basic message here is that we found that life event stress in these path models was associated with elevated cortisol that was in turn associated with reductions in left hippocampal volume. And we found that held for the left hippocampus in this case, and also the right hippocampus, although to a lesser extent, but still the same. And these relationships held up across sexes, although with slightly different pathways. But what we can see here is that there's a link between hippocampal volume and characteristics of life event stress exposure and also cortisol secretion. And in this study, a related study, we look at the relationship between hippocampal volume, cortisol, and effective connectivity parameters on fMRI. What we find is that basal cortisol was linked with lagged estimates in resting state connectivity from left to right thalamus. And basal cortisol was also linked in terms of bidirection for left thalamus. Lagged estimates from left to right thalamus were linked with right hippocampal volume. So structure function relationships that are established over time and may provide some leads on the sort of pathways from structural to functional and vice versa abnormalities in brain function. Okay, so in conclusion, and I think I may end here, we find that clinical high-risk syndromes are associated with a range of psychiatric outcomes. They involve deficits in cognitive, psychophysiological, and premorbid developmental functioning. They seem to be linked with a host of factors, distal, proximal, and neurodevelopmental processes, and lead us to the conclusion that interventions are likely to be multifaceted. So I'm going to just quickly go on and describe another line of investigation, but I won't go into details on the findings. So we are now looking at individuals with copy number variations. So these are genetic mutations that are typically de novo. They're acquired, they are not inherited. And one of them, previously referred to as DeGeorge syndrome, is 22q11 deletion syndrome, and another is 3q29 deletion syndrome. What's interesting about these syndromes is that they can confer dramatically elevated risk for psychosis and for many other psychiatric disorders, including autism, ADHD, and some physical disorders like congenital heart defects. Interestingly enough, when we look at these individuals, we find that they show, as we might expect, an increase. I'll move on to here, an increase in most of the positive symptoms tapped by the structured interview for prodromal syndromes. And some of those symptoms are linked with brain characteristics. Now, one of the things that is most interesting about 22q deletion syndrome, and probably also 3q, is that risk for onset of psychosis increases with age the same way it does in individuals without any known copy number variation. So developmental trajectories seem to be very similar, despite the fact that the source of vulnerability, copy number variation, differs compared to our clinical high-risk subjects. So I am going to just move forward and say thank you to the collaboration of all the investigators involved with Naples and all my Emory collaborators who have worked with me on Naples, my graduate students, my postdocs, residents, and my colleagues currently who are working with me on the copy number variation research, 3Q29 and 22Q11. So we're hoping that we'll have many more findings on these studies of individuals with deletion syndromes as we continue to follow them in the future. And I think I'll stop right there.
All right, thank you, Elaine. That was great. We're now going to see if we have any questions. And our first question is, in your judgment, what is the most powerful brain-based marker for predicting the onset of psychosis?
So far, I would say brain-based, a combination of indices of connectivity in resting state and changes in cortical thickness.
Okay.
And those are strongly related to cognitive functions.
All right, very interesting. Okay, we have a question from our audience up here.
Thank you so much for the presentation. What guidance would you suggest we offer in the outpatient clinic to best support families with genetic history of schizophrenia, particularly preconception? For example, if one parent has a sibling with schizophrenia and the other has a...
I think the last part of the question was cut off. But I should say one thing that we are increasingly interested in is preventive interventions that might reduce stress or enhance resilience in coping with stress, with the assumption that enhanced resilience in stress coping has the potential to reduce some of the neurobiological consequences of stress that are also linked with conversion. So, for example, reductions in cortical and hippocampal volume.
Okay, thank you. We have another question that's come across from a Zoom participant, and that is, can you say more about social fragmentation, how this was measured in the study you cited, and also what intervention do you anticipate would be appropriate to address social fragmentation and its associated impacts on social functioning? And if I could add also the effects of social fragmentation on brain development.
Mm-hmm. Well, in many respects, I think the results of our research using geocoding, which allows us to derive indices of social deprivation in a community, social fragmentation, etc., point to the importance of public health interventions that would be utilized to reduce morbidity in a variety of domains, not just psychiatric disorders, but other disorders. So in some respects, the geocoding findings are pointing to public health interventions and their importance in terms of psychosis prevention. In addition, some of the studies show that characteristics of the proximal environment are relevant, so that with greater social support, for example, the adverse effects of deprivation, fragmentation can be reduced. So, for example, we find that clinical high-risk children who attend schools that are rated better with respect to stability and quality tend to do better, even when they come from non-optimal neighborhoods.
All right, I think we have time for one very quick question. All right, this better be quick. Very quick.
Thank you for a great talk. I'm lucky enough to work and train in one of our CHR clinics here at the University of Rochester. Given the significance of the cognitive functioning data you presented specifically as a predictor, could there be any potential benefit of gathering that data kind of upon enrollment into a CHR program for a potential client, gathering a baseline cognitive profile?
Yeah, in fact, that was one of the objectives of putting together a calculator, a prediction algorithm. The goal of identifying measures that could enhance prediction above and beyond the prediction afforded by the attenuated positive symptom ratings. So we found several cognitive measures from the matrix that were helpful with respect to enhancing prediction of conversion. And they're measures that could easily be administered and are often administered in clinical settings.
Also makes you wonder if there should be more effort to improve memory and attention, the impairments that were the most severe. All right, so we are just about out of time. I want to thank Elaine Walker for a really great talk. I want to encourage everybody here to look up some of her work over the years, including the recent studies that she highlighted from the Naples and other recent projects. There's a lot there. And thank you all for coming. And please complete the survey for feedback. And I hope you all have a great day. And thank you again, Elaine. I hope to see you soon.
Thank you, Steve.
Take care.
You too.